Hello, everyone. Today we are going to do interesting case. It's basically distal left main trifurcation that we plan to treat with DK crush. And the interesting fact is that we are going to do this OCT guided. And today we launched our latest OCT software, which is called ACR, which stands for so it's a OCT with angio co-registration, which is really exciting, right? You get to see all the pictures, beautiful, fantastic pictures, and you get to correlate with the angiographic picture that is happening. So it's really very cool, and we want to use this latest device. We did the first case, which was a live case to Kolkata. That was the first done in Bangladesh, and this is our second case. So we decided why not, sort of make it into a live in box case and do it. So this is a elderly gentleman. He is in his 70s and he suffered from an anterior myocardial infarction a couple of weeks back. His ejection fraction is pretty poor, like 38%. He didn't get any medication because he was far away from Dhaka, and he came to us a couple of days back. We did his angiogram and we found that he had this severe disease and his ejection fraction had also deteriorated substantially. So our plan is today to treat him with the DK crush technique. Now let's go to the angiographic views and we'll explain why we decided to do this take. So we didn't take any pictures, right? I thought we would be showing the angiograph. Anyway, let's take some pictures and we have the pictures, right? We have the pictures. Or we can take. So, yeah, so you can see the angiographic views now. So there's severe distal left main disease involving the origin of the LAD. There's some disease in the proximal part of the LAD as well. The LCX is a very smallish vessel, right? You'd appreciate that. And there's a big ramus. So our plan is to do DK crush between the left main and the ramus, and we want to sort of just keep the LCX hopefully as the way it is. The RCA is a large sized vessel, and thankfully it is free of any significant disease. So this is the LAD, and you can appreciate that there's quite a bit of plug in the origin of the ramus. The origin of the LCX also doesn't look that good, but we think that it's not that big a vessel, so hopefully we will not be losing it or won't be creating much problem even if we do. Then let's go to the RCA. So RCA is a good sized vessel and free of disease. So it's an unprotected left main, as we can see, and the plan is to tackle this left main. So we have used a we've used a EBU 3.5 7 French catheter, and we've already managed to wire both the vessels. No, we haven't managed. So we've just wired one vessel. So we've wired the ramus, and now we plan to wire the LAD. So for the ramus, we took a cyan blue, and for the LAD, we've taken a run-through floppy wire. So we might need to curve this wire a bit. It seems to be a bit straight. So let's have a look. Can we have a bit of dive, please? We needed to curve the wire, I think. So we'll just reposition our catheter and no, we need to curve this. The wire is a bit too straight. So we'll curve it a bit, and curves do matter a lot, right? When you want to wire a vessel. Well, actually, the curve wasn't that bad, but it just wasn't torquing enough. So we'll give a secondary curve and a curve to the tip, and let's see how it goes. So at present, the plan is not to add the LCX, right? And then we want to do a OCT and correlate with our angiographic pictures and see the layout of the disease. Here, I suppose a bit of a challenge would be because in OCT you need to use dye, right? And here the ejection fraction is a bit poor. So we don't really want to sort of overburden his LV function. So yeah, so let's see. Huh? Can we go to the... So it's, I think, gone into a septal because we curved it too much, but that helped us get in the first place. So now we'll just go down. That's the trade-off, right? If you curve the wire too much, it'll go, but then it'll start going into smaller vessels. Can we have a look? Just a puff of dye, please. Okay, there's some angulation there, which is... So there we managed to go distally. Now let's have the OCT, right? So the plan is to go from the left main towards the LAD, right? And this will give us an idea about the origin of both the ramus, which we can angiographically also see is pretty hazy looking, as well as the LCX. Okay, so before the OCT, we need a lot of preparation, which I don't know at all. So we'll ask Moshet to tell us everything about how to prepare, right? So we're making this as a learner's guide to OCT as well, because we need to learn as well. And we've got Sunil with us, who came all the way from India to help us out and teach us. And so far he's done a great job.
Thank you, ma'am.
Yeah,
I'm
right.
Moshed. So let us know the OCT. Need first dock should be ready, which is dock cover. Definitely should be sterile. After that, need to catheter preparation. Catheter. This is OCT catheter. That's an OCT catheter. This is the side arm, which is TCC syringe Lollo. Need to fully dye contrast, no concentrated dye, should be forcefully flash.
Okay, great.
Before
we put this thing inside the patient's body.
The patient body. So dye should be at least 3 drops.
Should come out.
Should come out.
Okay, so we managed to spill quite a bit of, yes.
Yeah. Yes. Okay, thank you.
Yeah.
So dye should be forcefully flash. So main focus on only air-free. Catheter should be air-free.
And one of the most effective ways of making our catheter free from any air is by pushing this dye.
We need to connect catheter with the console. So this is the catheter connected to the console.
So can someone just focus on this? So
yeah,
so he's connecting the catheter to the OCT console. And the OCT console has already been covered with a sterile, transparent cover so that he can hold it safely. So now he's connecting it. Okay, right. Great, wonderful.
Yeah.
And the machine starts recognizing that we have connected it, and we've done it successfully, right?
So after connecting, you need to check
whether it's working or not.
Yeah, this is the lens is focus.
Okay, so you can show us. So
OCT.
You have to cover the light actually. I think.
Yeah, this is good. Look like choke.
So it looks like a eye, right? So you cover the OCT where the light is coming from the catheter. You just cover that up. Now we are all set.
Yeah.
So we'll put this catheter in, and you have to be so gentle with it. It's such a fragile catheter that it tends to break, and it's very, very expensive, you know. It's one of the most expensive things that you handle, and you have to be very respectful of the catheter. So he's doing a very good job. So you can see He put it in and it comes out very quickly, not like a balloon which comes out very late. So it's gone in and you can see the light sparkling there, and he covered that light to see whether it was working, and it did. So now we are putting this inside our catheter, and we need to be very careful. We don't want to kink it or anything, and it might kink, if you're not gentle, and it would just be the end of this very expensive catheter. So we are trying to push it in, be as gentle and taking short steps. Now we are in and we push our catheter in. Oopsie. And we are in. And I understand that the second marker is the marker for the camera.
Right.
So where একটু সোজা করে ফেলি আমরা হ্যাঁ
Sure.
thank you.
Right.
So wherever our now we need to push some more. So we are good, I think, right?
Yes.
We are good. Now
This is the
is that
position.
this is our position, and we think that we'll be able to see the
Yeah.
whole of the lesion. And
So
now comes the tricky part, right? You
now-
have to effectively push
Yeah.
the
you
dye,
have to
right?
Again, push the die. Parts.
Yeah, so we purge again.
Parts die. Yes.
So here we've purged.
Excellent.
Right
Yeah.
then.
Now, catheter is prepared. Put some nitro.
So we give some vasodilators. So this is a nitro. Now you need to be careful here, because you don't, if your patient is already hypotensive, you just don't want to just push a lot of bolus of nitro and make him more hypotensive. So we checked our patients all right. His blood pressure is around 115/80, which is, so we just gave him a bit of nitro.
Okay.
And now
This is concentrated dye.
Now it's what?
Dye.
Ideally, it should be 20 ml of concentrated dye. Here we are giving 10 ml of, and it
Yes.
should be a lower lock syringe, right?
Yes.
Yes.
Fully concentrated dye.
Yes. And Qayyum, being a very strong guy, he's going to do the pushing.
সামান্য একটু ডাই পুশ করে নিন ক্যাথেটার লোড
Yeah.
ক্যাথেটার লোড
cine.
ইয়া
Yeah, and it has to be cine, not fluoro.
ওকে সো
Yeah, he's going to give you the thumbs up, and then you sort of just.
I can ওকে আমি এখান থেকে কন্ট্রোল করছি কেমন কন্ট্রোল করে যখন আমি আপনাকে বলবো ওকে
Didn't do anything. He didn't do anything. This. দুটাই থাকা যাবে হ্যাঁ Okay, he's now do it. So this is the angio co-registration. We take a angio acquisition, and we also do the auto pullback in the OCT. So now we can correlate which lesion is where in the OCT, right? So we've done it. How did we do?
yeah good
Put this first guide marker,
yeah
second marker, third, and attach it with guide catheter.
sure
Then continue.
একটু বাইট করে ফেলি
Then confirm.
বাইট করতে হবে এটা
So we have
we are getting this out. So now Moshed will explain what they did. So Moshed, will you care to explain to us how you did co-registration? And so this is the beauty of this new software upgrade that we did with our OCT machine. So you can co-register with your angiographic. So Moshed, can you explain it to us?
yes ma'am actually this is the angiographic views directly comes to from our OCT machine and we can just mark to the OCT distal tip then middle of the T is the tip of guiding catheter.
Okay.
we
So these
continue.
are our reference
Okay,
points.
so we got the distal, mid, and proximal.
Yes.
Confirm. Accepted.
Okay, wonderful. So now
So
can we explain the pictures to us,
yes,
please?
ma'am. This is the marker of the distal T. I am coming distal to the proximal.
So there the vessel looks pretty good actually,
Yes,
right?
ma'am. This is
The
the lumen
vessel looks pretty
normal
good here,
segment.
normal segment, right?
Normal segment. There is no significant stenosis. No significant stenosis. The one marker is coming from the coronary, and another is going on to the OCT. There is a side branch.
Yeah, yeah. So we can correlate.
Correlate with that is the side branch.
Yes, we can see the
There-
branch
yes,
beautifully
yes,
free of
ma'am.
any disease.
And there is no, yes, ma'am.
We have to.
So this is the big diagonal. We got the diagonal perfectly. This portion also disease free.
Then we enter the
Then
disease
coming
segment. We
from
can see, yes.
proximal, this is the segment which is the distal landing zone. Yes. This is the maximum stenosis portion. Coming to the distal, proximal.
So can you explain the
coming.
disease
Yes,
to our-
severe stenosis from the proximal LAD.
And what kind of a plaque burden is this?
plaque-
There is not much
There
calcium,
is
right?
no significant calcified. There is a small soft plaque.
Here it is more of blood because of tenable speech.
Need more dye.
More dye is needed, but still, we can very well see that there is no calcium usage.
Great.
And the distal landing zone, which sir is saying about it, this is the distal landing zone. Length, we will just situate EL to EL, which is media to media.
Almost 3 millimeter.
And
The
which
vessel is-
3 point, average is 3.15.
1.5.
So whenever we give media to media, stent size should be 0.5 less than 5.
Less.
Okay, so that's very important. So we measure from media to media, but our stent size has to be 0.25 less than
Less than
this.
media.
So if we get a 3.25 measurement, we'll put a 3 millimeter
3
stent.
millimeter stent.
A 3 millimeter size, we put a 2.75 millimeter stent. So
Yes,
that's
yes,
so
yes,
we get
yes.
0.25. So let's now start the work. So great pictures. So now we will start our pre-dilatation. Do we need, this is acute coronary syndrome. So we won't do any pre-dilatation. We'll first put a balloon in the left main to LAD and put a stent from left main to ramus. রামাস তো নিচের ভেসেলটা তাই না আপনি তিনটে বার করেন কেন না প্লিজ নিচেরটা না Does anyone want to put a wire in the L6? I don't think so because we'll have to remove it anyway. খারাপ লাগতেছে একটু সিডেট করা যায় না ওনাকে বাবা ভয় পেন না হ্যাঁ ইনশাল্লাহ so we are taking a stent for the 2.580 so this is our stent for the ramus a 2.75 18 right and now we're going to put a balloon from left main to LAD which is a 3.5 by 12 a 3.5 by 12 So normally we would pre-dilate, right? That's mandatory. But here we don't see much calcium. And the other fact is that he suffered from an anterior MI very recently, and we don't want to disturb all that plaque over there. The stent is ready. I'll push it a bit. I think that balloon is a bit too short, right? Are we all right? Yeah, so that looks fine. We don't need to. No, we don't need a check. I think yeah, stent, deploy the stent. Yes.
2, 4, 6, 8, 8, 8. Down.
We'll pull it in front a bit, and then we go again. And now we go up to higher pressures.
14, 16.
So let's have a look, and we'll take our wire as well as our balloon out from this. Okay, our L6 looks fine. Ramus looks good, and we're going to remove both these wires as well as the balloon now from the ramus, and after this we will proceed to crush this stent that was deployed in the right. So we've got a balloon already there, and with this we crush our stent. It's properly positioned, right? Yes. So
4, 6, 8, 10.
I think this balloon is a bit too short. Maybe a little.
16, 18, 20.
Okay, great. Want to crush it some more? No.
12, 14, 16, 18, 20.
One issue about pulling back your balloon like that, you might dissect the proximal part, and then rewiring might be a bit difficult. So now we've got a crush stent in the ramus, and our plan is to rewire that. So our wire is now in the LED. We cover it with a napkin, and we are taking our wire for our ramus. Now the ramus is a pretty straight vessel now, which makes it a bit. Let's see. Fingers crossed that this wire might go easily into the. Let's see how it behaves. You never know, because you've got 2 layers of metal now crushed, and you need to go through those layers. And so doing a thorough job of the crushing is a good idea for successful rewiring. Bit of a challenge, right? Yeah, yeah. Good. No? So we might need a new. Okay, it went. Great. So now we open up the strut with a 2 mm balloon. After we've opened up our strut, we will do our first case. Okay, so we'll open up our strut.
2, 4, 6, 8.
Yeah, so our balloon went very easily without any resistance, so we're in the right place. We'll now take our 2 balloons for the kissing. So we are taking both NC balloons. So LED, we are taking It's a 3, right? 3 by what? 12? And for the, so short balloons, both NC balloons. So okay, so this is our LED balloon, and now we take a 2.5 by 12 NC balloon for our ramus. And kissing has to be simultaneous. You want to inflate and deflate in the same time. So, so we've got both our balloons in position. We're good, right? So,
2, 4,
someone.
6, 7, 8, 10.
So that was simultaneous inflation as well as deflation. Now first case is over and we have to remove the wire and the balloon from the ramus again and deploy our stent in the LED. Okay, so now I'm removing the wire from the ramus. Let's be sure you don't want to remove the wire from the LED, right? So this is the ramus, right? Okay. So we've removed the wire from the ramus and we're going to stent from left main to LED. So we're going to do it from mid shaft, right? The ostia of the left main was pretty good. And we haven't taken much shots, you will notice, because you want to keep the dye as minimum as possible in a patient who has compromised LV ejection fraction. And one thing I like about DK crash, it's like a formula. This step, then that step. So if you know the steps, it's like pretty straightforward. And you can do it in any type of angle, which is pretty good. And you never lose excess of the main vessel. Right. So can we have a look now to properly? We saw that in the OCT, so we'll put it over there. Can we pull it back a bit then? Right. See, right. So can we have so in the angio core it has to be a bit more up, right? According to the angio core registration, it has to be here. So what size of stent did we use? Maybe, please. Yeah. So we've covered. Have we covered the ostia? Just falling short of the ostia, right? Yeah, because the ostia was.
Okay,
Yeah.
position.
Yes.
2, 4, 6, 7, 8, 9, 9.
The nominal pressure is 9, right? So we can come down again. It's not going to tolerate long times of, ischemia. So for left main, your inflation times should be as short as possible. And another thing is keep the dye uh, dilute. Do we go up with this, or we can take a smaller? We take a smaller NC balloon and cover post dilate the entire length. So now we've deployed both our stents, but the stent in the LED needs some further work because we need to properly oppose it for good long-term optimal result. So we're going to take a 3.5 NC balloon. So this was a good idea to, just to do the OCT today. We're all learning the steps together. This balloon's a bit bulky, you see. It's been already used quite a few times. And the stent is also not fully deployed. Yeah, we can dilate here because we're inside the structure.
8, 10, 12, 14, 16, 18, 20.
Okay. It's really bulky. Okay. So we'll go down maybe.
10, 12, 14.
And the last bit is not obviously we can. Oh, okay, so let's go for with a 3 then, because the caliber there is not obviously, so we don't want to risk it. Even though it's a NC balloon, this you need to remember, with the oversized balloon, there's always the risk of perforation, which obviously none of us ever want to. So now let's, for the distal part also, maybe with an undersized balloon, maybe a 2.75 or something, go up. We did dilate it. Okay. So he wants to post dilate the distal part later, which is fine. So now what we have a wire in the LED, we will recross into the ramus again, and after that do our final kiss and report, and that's us done actually. And we'll of course obviously do a final OCT run as well. And so now our wire has to cross 2 layers, and it's always nice to have, nice new wires. These wires have already been used a couple of times, which might make it a bit difficult to cross. And the wire's a bit too curved. Didn't straighten it up. Oops. Need to make the catheter coaxial. It's not coaxial. That's another reason that the wire is behaving the way it is. Oops. Now it's not sitting in the ostia. So we didn't cover the ostia. Maybe a microcatheter would have been of help, right? Okay, so now we are in, but we need to cross. And always try to keep your gloves and hand as free of blood as possible. That makes it more easier to do your work. So now it has to. So this wire I feel has not enough strength to go through 4 layers. If we had a uh, if we had a micro, maybe it would have given adequate support, but this wire by itself is not going to go anywhere. It's too weak. It doesn't have the strength to go. So, so we've got 2 choices: either take a micro or take a new wire. So it's going there, but it just doesn't have the strength to go through, right? So can we have a micro, please? It's almost in. Okay, so it doesn't want a micro, it went by itself. Great news. So now we'll again open up the strut and then do our final kiss and then a pot. So we use this so we use this wire, this balloon before also to open up the strut. So we are doing that again, a 2 millimeter balloon, and we open up the strut. After that, we do our final kiss. And yeah, so here, let's see. I think we haven't lost the LCX, which would have been, which was one of the challenges of this case, right? because with the trifurcation, but the good thing, our saving grace was that it was of small caliber. So now we're opening up the strut.
2, 4, 6, 8,
That's our strut opened.
10, 12, 16.
Okay. So now we take our balloons. Yeah, so this is going to be our second case. So we're taking a, 3 by 12 NC for the LED and a 2.5 by 12 or 15 for the Ramos. So this one's the Ramos. What size is this? Yeah, so it goes to the LED. And that's another thing, you need to remember which wire is going to which vessel. One easy way of doing that is use different colors of wires and keep them separated by a napkin. That really, so there's less chance of twisting of the wires, which is really very good. So our balloon is going now into the LED. Let's see how it behaves, because it's been used quite a few times and it's quite the yeah, well, Moshad wants to post dilate now with this balloon. Okay, we can do that before we do our final case. So we can see there's a bit of under expansion of the
12,
stent,
14,
which is
15,
so okay,
20.
great. So you have to be pretty aggressive with your post dilatation. You really want your struts to be, be there in the wall, not floating about. So now we're going to use this for our case. So uh, this is 2.5. Yeah, we needed 2.5 for the rammers. And we are all very excited about the OCT and the angiographic co-registration, because we are part of a trial and we'll soon start recruiting patients to see how OCT optimizes our results. And it's going to be a very exciting chapter in imaging, I feel, and especially with distal left main disease. I mean, you need some form of imaging. Personally feel IVUS is a great tool, but my experience with OCT is not that extensive. So we need to learn about OCT, and I'm sure it's going to be very, very interesting. Now, this is a challenge, right? The balloon is very bulky, and we'll push that other balloon a bit distally. That will give us enough space to negotiate this balloon. Actually, when you're using new, unopened balloons, it's easy. But with bulky balloons, it's always a challenge. Okay, it went fairly well. Now we pull back the other balloon, and this is now our positioning, and we start our kiss, right? So Moshad, go.
2, 4, 6, 7, 10,
Dra. So it has to be simultaneously. Now we're going to do report. So for report, we're going to use a larger size balloon, large but short, because we do not want our balloon to cross the bifurcation, because that would really play havoc with the stent struts, right? So it has to be a short and large balloon, which will expand the proximal part of our stents nicely. So it's a 4 by 8 that we're taking, and we're going to take it across the LED and place it just proximal to the origin of the LED and the LCX. So the wire is the one that is going through the LED, and this balloon is just going to be used for repotting, and it's going to be placed in the left main proximal to the origin of the So there we are. So this is where we want to place it, right? It's before the bifurcation.
2, 4, 6, 8, 10, 12, 14, 16.
No, no, I think we're out, Moshe. You don't want to get out of, yeah, so, right. Yes, so we can,
Yeah, 2, 4. Yeah, 2, 4, 6, 8, 10, 12, 14, 16, 18.
so do you want to do the OCT and then take a final shot, or do you want to? Yeah, okay, absolutely. So during OCT, we're going to take the cine as well as the angiographic co-registration. Yes, great. Can I have some gauze, please? Yeah, so this was our concern, ejection fraction being very poor. So we'll give some nitro again, just like 25 mics of nitro. No, we're going very soft. We don't want any surprises like sudden hypotension or arrhythmias or anything. So the trick is to be as gentle as possible and making the catheter, sit on the ostia. Then otherwise you spill the dye out, which is not a good thing. Patient might suddenly drop his pressures. Okay, so now we're going to again go through the. So we're going in, Moshe. So the dragonfly, that's what it's called, right? It's more delicate than a dragonfly. You really have to be so gentle with it. And we put it in. Why did they call it a dragonfly? They could have called it a firefly because it's got lights on. So it's in. And now, so after the fragile part, the rest of the body is pretty robust, not that bad. So someone needs to pull this for me. Yes, please. Thank you. So getting it in might be a bit of a challenge. So the second marker is the camera, and we have crossed. Yeah, it take to. Right. We're good, right? So Abdul Qayyum.
GTN, nitro.
I already gave, and the pressure is a bit low. But can you do it with this syringe? It's more of a suction syringe. Will it go? We're using a suction syringe to give. Yeah, yeah, 16. Don't give the whole thing, na? Okay, wonderful. Yeah, don't have to push that hard, right? You have to push hard? Yes, it is.
Ready? Cine.
হ্যাঁ না দেখাবা না প্রক্সিমাল জিনিস তো এখানে ডিস্টেলে কি দেখবা Okay, fine. So we had some blood, right? That's acceptable, huh? So we'll pull it out right now. So we did a DK crush with the uh, OCT. How much dye did we use for the whole procedure? Yeah, we didn't use much. So we've in a 100 ml bottle, we've still got like 20, 30 ml remaining. 2 OCT runs and a double stent technique for the left main. So that's pretty cool, actually. So I mean, now I'm becoming a believer. I was always a skeptic. I used to think, okay, with OCT you need such a lot of dye, and how can you use it in a patient who's got compromised ejection fraction? You can do it if you sort of strategize. So we are done, right? You want to show us the final runs, please? Okay. And do we want any more shots from here, or we are finished? Just let's have a look at the OCT. নাড়ানোটা বোকামি হয়ে গেছে ওটা বল uh-huh. Yeah, it's beautiful. And the stents are all nicely opposed, right? Struts are. Hmm. Ah, yeah, it's proximal strut crossing. Beautiful proximal strut crossing. You need a proximal strut crossing. It should be distal strut. Yes, yes. Proximal strut. So there's a Carina option also. Beautiful.
এটার কোনো এক্সপ্লেনেশন কিন্তু আমরা শুনতে পাচ্ছি না।
Oh, so he can't hear any explanation. So we have to give this to. So you have to, as yes,
Once again,
please,
in
yes.
case of in case of OCT, especially the physicians who do a lot of bifurcation stunting, this mode is particularly for them. That is 3D bifurcation mode. We have to click on 3D bifurcation mode. Immediately we have this part, and in this part we have the options whether we have to guide wire 1, guide wire 2, or side branch. Since we wanted to know particularly the DK crush, how is our crush? So here we will clearly see that the second guide wire is actually crossing the proximal part of the strut. So the result which we got it because of the proximal part of crossing this is much better, particularly in this case. Apart from that, there is one more option in it, is the Carina view. The movement at any moment of time wherever we are, for example we are here, and to save that time we will just click on that and automatically it will come to this part. Apart from that, wherever we see these pink dots, These are the pink dots which states that there is a branch which is exactly going to a side branch which is having more than 1.5 mm. And while deploying the stent and with the help of ACR, we can precisely placed. So here again the advantage was there was 1.5 mm side branch which is going here, but almost our landing zone was avoiding this side branch. So we have not compromised this side branch. This is also one of the good part with this case. And apart from that, if you go to this 3D navigation mode, here we will again have the same kind of whole thing where we will have whole stent to see that. Especially when you wanted to see a stent fracture, you can just click on stent only. The moment you will click stent only, you will have only the stent. So angiographically, sometime if the stent failure miss, here with this mode you will have completely things. And this is again, ma'am, which we are talking about the proximal strut or crossing or not. Apart from that, at last we will just go through the fly through navigation view, which is again available only with this view. Just click this, and now we are going to,
It's really nice, right?
yeah, so now
It's
we are
like
going
a science
into this
fiction.
sky through view. So wherever, usually because again there was certain blood, that's why it has not been. Otherwise, wherever there is a red complete marker, that means that area is malapposed. From here also you will able to see it.
Looks pretty good actually. Don't see any malap. It's fine. If you see, and we'll just give her the first shot and this last shot, for our viewers to remember how we started. And we didn't lose our LCX. Okay. So that's us done. No more post dilatation. So we are good. Thank you. Yes, all of us.
Yeah. Okay.
So we just made history.